My name is Niall Downey. I'm from a company called Framework Health. Basically, my aim today is to try and convince you that error is ubiquitous, that we can't avoid it, so we're just going to have to learn to deal with it. Secondly, have a look at our aviation system, and then thirdly, dig a bit deeper into that, looking at our sort of crew resource management philosophy. And so any comments along the way, I have the chat bar open here as well. So if you have any questions as we go along, feel free to put them in there and I'll try and keep an eye on them. Get this to move. There we go. Right, so if you want to get in touch, we have a website, it's frameworkhealth.net. There's direct links to me on that. I have a TED Talk from 2016 on that. And I'm on Twitter and LinkedIn. So I'm easily contactable, and any comments, criticisms, suggestions, all very welcome. So why am I here? I fly one of these yokes across the Atlantic every 5 or 6 days or so. So I'm a captain with Aer Lingus on our A330 fleet. So currently based in Manchester, been there for the last few months now. And my aim is to bring our aviation safety approach and apply it into healthcare. Now, I know you've heard that before, and you've had people telling you for the last 10 years it's all very transferable, and we're regularly told that it's not transferable and we don't understand the differences between health and aviation. So my background is I'm also a recovering cardiothoracic surgeon as well as a pilot. I qualified as a doctor in Dublin in 1993 and then trained as a cardiothoracic surgeon in between Belfast and Dublin, and couldn't get training posts back in the SPR system back in the 90s. So I was left with no option but to jump ship. So 24 years ago, I joined Aer Lingus and I've been there ever since. So for the last 12 years, I've combined the two and tried to bring our aviation safety philosophy into healthcare. Now, we keep getting told it's two different industries, and it's two very different industries. I think about 10 years ago, some BA pilots tried to transplant our system into healthcare and it got rejected because it was a bad tissue match. But I believe the underlying DNA is very compatible, and that if I explain our framework, you can then take it and apply it to your own environments. And some of it will fit, some of it won't, some of it will need modified. But I do believe the framework is compatible with healthcare, and that with you guys on board, we can try and make it work in your environment. Now, each one of you is going to be different. You have different environments, different workplaces. So some of it will work, some of it won't, but I definitely think it's transferable. The basic underlying premise is, have you ever made a mistake? I think that covers most of us probably. So just try and convince you of that. We'll look at a few mistakes in various walks of life and at various levels. So let's start at the very highest level. Let's go to the Miss Universe contests run by a certain Trump organization. So you can hear the audio on that as well. What happens, they presented the crown and first prize to the first prize winner, obviously. So there she was there with her crown and her flowers, and then it suddenly dawned on them that misread the card. It was very badly laid out from a human factors point of view. The person that given the prize to wasn't first, she was first runner-up, also known as second. So Miss Philippines actually won. So live on stage in front of millions of people on TV, they had the dethrone her and hand the crown and the flowers over. So talking live TV, let's come back to Ireland here. This is one of our best known newsreaders in Dublin, Angus McGreena. Live in the 6 o'clock news. Okay, so live TV has problems on other sides of the world as well. So let's have a look at Australia. Right, so that's entertainment, live TV. I live in Northern Ireland. I'm just outside Newry here. So there was a famous TV show filmed here over the last few years called Game of Thrones. See if they made any mistakes. Okay, so at least they're able to edit that out and do it again. Some other bits in Game of Thrones weren't edited out. If you remember the climax coming towards the end of the final series, there was the big war council, and Jon Snow was sitting beside Daenerys. As you can see, he left his Starbucks on the table during the meeting. So that actually made it into the final cut. So that's actually in Game of Thrones if you ever watched the final series. That's entertainment as well. Politics. That was the biggest security event in Ireland this century. A friend of mine is the head of the Garda Sub-Aqua unit. They were patrolling all the sewers under Balls Bridge, looking for suspect devices that week, and then they had to weld all the manhole covers shut when they came out through them. They had helicopters all over the place. They had all police leave cancelled for the whole duration of the visit. And here's the beast leaving the American embassy, and it got beached on the way out. Now, it actually came in through a different gate, which is why it didn't happen on the way in. But the car was stuck there. So it's bulletproof, bomb-proof, chemical weapons-proof. But it's now sitting there as a sitting duck with the President of America. If there was a terrorist attack on him, he couldn't move. Sitting there as a sitting duck. Now, one of the things I'll be teaching in a wee minute is where can this go wrong? What's plan B? And you can see the Secret Service apply that as well. If you look carefully, there's always two beasts. And even the Secret Service don't know which one he's in. So it turned out by pure fluke that day, he was in the second one. So it was able to reverse back and go back out the other exit. Okay, so talking of politics, who can we always rely on for errors? Right, so we've covered live TV, entertainment, politics, a bit of sport. Not Cristiano Ronaldo. So we look at one more just to prove the point. So I used to be a pro-am international cyclist. So the biggest annual sports event in the world is the Tour de France. Here's Adam Yates. So the entire race brought to a standstill. So it happens with 1 kilometre to go. There's a red kite hangs above the road to let the riders know. That year's Tour de France, they decided they would hang it off a bouncy castle. So there was an air compressor at the side of the road, which was keeping it up. One of the spectators leaned forward to see the riders coming, caught against the plug that was plugging it into the generator and unplugged it, and down it came and stopped the entire race. Okay, so I think we've probably made the point now at this stage that human error is everywhere. It didn't happen back in the days when I was riding Pro-Am Internationals, of course. I even got birthday cakes on my birthday in races. Right, so the bottom line is error is nothing to be ashamed of. It happens everywhere, every walk of life, every industry. So our approach in aviation is not to be ashamed of it. It's just something to be dealt with. So what about healthcare? Any errors in healthcare? So looking at some figures here, there's studies by Charles Vincent from London, going back about 50 years. If you look at the adverse event rate on the right-hand side, we can see that average is about 10%, and it's internationally accepted now that the adverse event rate for hospital admissions is about 10%. And all the studies for the last 50 years have shown that. And interest.
Sorry,
Yep.
just to interrupt. On the screen, I don't know if other people are seeing it, is the embarrassed goalkeeper footballer. So we haven't moved the slides on. You might want to have a.
Well, they've moved on my side.
They've moved on here as well.
Oh,
It's on here.
Me.
And
All
me.
Good. Carry on going. Ignore me.
Over yours will catch up shortly, Helen. Yeah,
Yes.
I'm on the NHS Captain Safer slide. I presume everyone else is seeing that, yeah? So
Yeah, I
basically,
think you're right. Yeah.
that's for the NHS. Again, this is a study done in 2015. And again, the number of adverse events in hospital settings is, again, averaging around about 10%, same as it was 50 years ago. So that hasn't changed. Figures in the States, this is Marty McCarry. He's actually from Liverpool, but he's been a consultant in Johns Hopkins for about the last 30 odd years. He did an analysis of the American health service and came up with very similar figures. And when you worked out the numbers, it made it the third leading cause of death in the States behind cancer and heart disease. To come a bit closer to home, back to Dublin, I'm a fellow of the Royal College of Surgeons of Ireland in Dublin. They did a study back, published it in 2016, doing the exact same sort of research as everyone else, but it had never been done in an Irish hospital before. And the interesting bit at the bottom there is the figures are consistent with baseline studies in other countries. In other words, the same figures we've just been looking at. And we dig a bit deeper into them. You can see at the top, it was all the big guns were involved in the research. So it's fairly well funded and well covered research. They found 12% had an adverse event. So again, about 10%. 10% caused permanent impairment, so long-term disability. 7% either caused or contributed to their death. And their figures showed about 70% of events were considered preventable using aviation safety techniques. That's Ireland. What about the NHS? So again, we've seen that the figures there are fairly similar. So if we look at costs and the number of admissions first, this is figures from 2018 to 2019, so just before COVID to get a more realistic sort of figure. 17 million admissions in 1 year. So if 10% of them have an adverse event, that's about 1.7 million. And if about 7% of them it either causes or contributes to their death, that's around about 120,000 deaths per year from adverse events. And I think the NHS at the minute are claiming 11,000 deaths per year. If you work through their own figures and their own stats, it's about 10 times higher than that. So you put that into context. 120,000 deaths per year. Say I'm in Northern Ireland. Say we even take that from Northern Ireland. This is an A320 that I used to fly out of Belfast. There's 174 seats there. If you take the number of adverse events, just in the small area of Northern Ireland, we would fill that plane once a month. Now the UK is about 30 times bigger than Northern Ireland, so you're filling that plane basically every day. So that's the sort of figures we're talking about, and it doesn't get reported in the news, and you don't have to tell the regulators. So that's a great deal. What about costs? Again, figures internationally show that adverse events cost about 10% of an entire healthcare budget, and that's been found to be consistent across the world. If you look at figures for this year for the NHS England alone gets about 160 billion of the total healthcare budget, which is about 190. So if you take the NHS England alone, that means about 16 billion of that is being squandered on adverse events. And if 70% of that's preventable, according to Healthcare's own research, that means we could save around about 10 to 12 billion pounds a year on the table, up for grabs. And Steve Barclay tells you can't give you a pay rise. So the money's there, it's just been spent on the wrong stuff. So what about aviation? How are we getting on? So here's our stats going back to the last century. It goes back basically to the Wright brothers, and that's figures up to about 2010. If you follow the trend there, you can see it's a steady upward climb, bit of a blip for the Second World War, but steady climb up to the late 70s and a steady drop off ever since. So that's accidents and incidents. What about deaths? Exact same trajectory, steady climb, bit of a blip for the Second World War, and a steady drop off since. If you look, it peaked around about 1977 and it's been dropping off ever since. So what happened in 1977? That was the Tenerife disaster. We had two jumbos collided on a runway in the Canary Islands and killed almost 600 people in one shot. And that led aviation to think, right, we're going to have to do something about this. This can't continue. And it led basically to what's now human factors. We've been fine-tuning it for the last 50 odd years now. We still haven't finished it. So it's still a work in progress. But you can see the results we've had. Back in 77, there's about 3,000 deaths per year. The amount of aviation has increased about 9-fold since. So if that had continued, we should be seeing about 27,000 to 30,000 deaths per year. Internationally now, this is commercial jet aviation. Internationally, figures are showing less than 1,000 a year on average. Now that's worldwide. So we're going from what should be about 30,000 deaths to about 1,000. So that's about a 97% improvement. Healthcare research shows a 70% improvement. So I think 70% will be the starter even. So what are we doing that's managed to get those sort of results? Big difference, first of all, is culture. I know when I worked in healthcare, if you made a mistake, it was name, blame, shame, retrain. And from speaking to a lot of yourselves, I don't think that's progressed very much. We have what's called a just culture. So if I make a mistake tomorrow, I can put my hand up and admit it, and I can't be disciplined and I can't be dismissed. Now, people talk about a no blame culture. It's not a no blame culture. I'm flying a $240 million airplane with 300 people on board. If I do something stupid, I will be blamed. But the difference is I won't be dismissed. We'll look into it and see what went wrong. We'll think it's obviously something wrong with our system. You've been flying for 20 odd years. If you were a crap pilot, you'd made this mistake before now. So we look in the system, see what went wrong today. And then we apply our crew resource management philosophy. So basically we expect to make mistakes, and we have a whole procedure built in for everything that we do, everything we design, all our working systems based around expecting things to go wrong and trying to manage it. So basically accept error as normal, so it's nothing to be ashamed of, so we can put our hand up. We look at our systems, we usually find there was a tripwire there, and we try and replace them then with safety nets. And we train our staff to manage error. Now, that's our three-stage process. Pilots are fairly simple creatures. Some days we're only firing on 2 neurons, so we have a 2-stage process as well. This is basically summarize all you need to know from the whole 30 minutes. Where can this go wrong, and what's plan B? So everything we do is based around that. Where can this all go wrong on us, and what's plan B? And the exact same process then can be brought into healthcare. I'll see a few examples in a minute. And just on the subject of changing things, I know when I give talk to the Belfast intensive care nurses a few months ago, whenever they had a medication error, their final result was generally that they added an extra layer of workload to their system. So they made a mistake because they were overworked, under-resourced, trying to mentor people. And how do we resolve it? We increase the workload even further. So that doesn't work. We're going to have to reduce the workload, so there has to be a what's in it for me. So to summarize, first of all, what we mean. A lot of stuff you've probably gathered now is endemic stuff that the Minister for Health needs to be changing for you, or your managers need to be changing. That's not going to change anytime soon. What we supply is personal protective equipment, so we expect mistakes to happen, and this is to try and protect you against them. It doesn't make them go away completely. Your own research shows that we can reduce the error 70%. And it provides a framework for safety. So basically, you provide a background approach, which then needs to be modified for your own environment. You can't just take our approach and transplant it. That won't work. This is too different. But our framework can be modified. Now, I see a few people seem to be getting stuck back on older slides. We're on 34. It seems to be moving slowly for some people. So maybe the internet connection on your side. Okay, I'll keep going in the meantime anyway. So basically, let's compare the two environments. So here's your environment. I work in cardiac surgery, so we used a lot of heparin to thin the blood before we would go on bypass. So we can see here's two almost identical bottles of heparin. Same size, same shape, similar labels, similar colors, similar names. But the difference is the one on the left is 1,000 times stronger than the one on the right. So where can this go wrong? And guess where it went wrong? A lot of kids have been injected with heparin 1,000-fold stronger than they were meant to get when they were flushing IV lines. And one of the most famous cases was Dennis Quaid's children in the States. Now, they were lucky they got away with it, but there was some mistake waiting to happen. What about in the high street? Here's a couple of bottles from Boots. So your child's got a bit of a cough. You go in to get some simple Linctus. You're in a hurry. You're trying to make the last bus home. You run in, you grab the bottle, and you head off home. Now, what's the chances of you lifting the wrong bottle? And a few years ago, that's exactly what happened. There was a parent grabbed the bottle of hydrogen peroxide, went home, gave it to the child, and the child ended up with burns to their mouth and tongue and throat. Okay, so that's in the high street. I spent a lot of time in intensive care, obviously, with cardiac surgery stuff. So we had patients on renal dialysis. So here's 2 bags of renal dialysis. Now, one of the big things you're aware is you have to be very careful of potassium levels, because especially in cardiac surgery patients, we can tip them into VF. So 2 bags here. Is there any difference in them? Now picture yourself 5 o'clock in the morning in the side room in intensive care, knackered, tired, you've missed your breaks, and you're on a 12-hour shift. Or if I was in the Mater, I was times on a 56-hour shift. The difference is the one on the left is twice as strong as the one on the right. You can see there's a 4 there, so 4 millimoles of potassium versus 2. And they've also got it written a second time down there, 4 millimoles versus 2. Now, what's your chances of getting that wrong at 5 in the morning? I would say pretty much guaranteed. So back to the high street, a lot of pharmaceutical companies then blame the staff, saying that you weren't careful enough, you didn't read the instructions, you didn't read the dosage properly. So let's see how they get on when it's their side. This is my daughter buying a pack of Lemsip in college in Edinburgh last year. Now, if you read the ingredients, active ingredients per capsule, half a kilo of paracetamol per capsule, anyone? So they make mistakes too, but that's different. So you can see your environment. Basically, you're working in a minefield. To be honest, it's amazing you do as well as you do. So what about my environment? So anyone guess what this does? So it's a lever with 2 wheels on it, and you have 2 options, up or down. So if I'm coming in the land and I want to put my wheels down, you grab that lever. That's our simplistic approach. That's a $240 million Airbus. Outside, we paint panels red. So if the engineer's doing a walk around, if he or she sees any red, they know there's panels left open. If the plane's in for maintenance, if we lift that lever, the wheels will retract if the plane's up on jacks. So if there's an engineer working up there, they'll get crushed to death. So to avoid that, we can put a pin in that little hole up there, which mechanically locks it so that the wheels can't come up and protects the engineer. That's the pin there. It's about the size and shape of your little finger. So you can work, can this go wrong? If they forget to take it out, and then I'm heading off down the runway later that day, and I take off, I take the lever up, but my wheels won't come up because they're mechanically locked in place. So if I'm on a long flight, like say going to Washington or something, I know I can't go because you can't fly with your wheels down. So I know if they come back in and land, overweight because I was planning on burning about 20 tons of fuel. And basically if they declare an emergency and possibly set my wheels on fire, my brakes on fire and so on. So it's a big deal. So what's plan B? You probably think it's something stupid, like hanging a big 2-foot long fluorescent yellow flag off it. Yeah, that's exactly what we do. And for the terminally stupid, we write a remove before flight on it as well. Okay, so we make mistakes all the time. We report stuff to our air safety office. They get about 20 reports a day, and we're a fairly small airline. And at the end of the month, then they put the important ones together and send out a feedback notice. They let us know what's going on in the airline. So we get information very quickly back. It's all de-identified, so we don't know who was involved. We don't name and shame anybody, but the information gets out there. Compare that to your world. Anyone who puts their hand up and reports anything is called a whistleblower, and we know how they get treated. I've never come across a whistleblower who was treated well. We then take that information and we use it to design our training. Now, the biggest accident in the last, or this century so far has been the Air France crash, where the 330 crashed into the South Atlantic. Within weeks of it happening, Airbus had worked out what they thought had happened. Remember, the black boxes weren't found for 2 years, but they had some information from telemetry, like the Grand Prix cars do, which they were able to put together and work out what they thought happened. And it turned out what they came up with was fairly accurate. So we know, like basically, the guys put the plane into an unrecoverable position and couldn't get it back. So we're now trained how to put the plane into crazy positions and then recover it. So here's me in the simulator, and it's our 320 simulator. Keep an eye on the horizon out there. Picture yourself sitting there. Put the plane in crazy position. Keep an eye on the horizon out there. Make sure you're nothing is at this stage. You've only got a few seconds to recover that. Clean up the chair. Recover it fairly quickly. I give me 6 minutes. Set the place. A, stop skipping that position again, your horizon. And B, how to get back out of it again safely. That was being trained by Airbus operators worldwide within weeks of the accident. And there hasn't been a similar crash since. We also train with the cabin crew here once a year. So this is our mock-up for cabin crew training. Now, you probably know in Aer Lingus all our planes are named after saints. And in Aer Lingus, we have our flagship, the St. Patrick, which is now based up in my base in Manchester. So we think our artificial planes should be given the same courtesy. So we do our training in the synthetic. So that's what the cabin crew do their training, and we train with them once a year. So that's what it looks like inside. So they can do various procedures, dangerous goods procedures and so on. And the most important one, our biggest fear in aviation, is if we catch fire. So we can now fill it full of smoke, and we can train how to put on a smoke hood, go up, find the door in zero visibility, open the door, and then go back and find any passengers to get them evacuated. And that's what we're looking for the door. Again, approach. This is Heathrow. When we're taxiing in the evenings, we follow the green lights and stop at the reds. This is to stop us taxiing on the runway by mistake, which is one of our big problems at the minute. So a big red sign warning you about the runway and red lights warning you not to go onto it. This is me lined up on the runway in Paris, Charles de Gaulle last year. It's telling me not to take off because there's an airplane crossing the runway down the road from me. So simple approaches like that. Again, we've seen the idea about painting things red. So that's the cargo holes. The cargo hole's still open, so it's not a good idea to go. We do the same with passengers. We assume you guys make mistakes as well. So this is the baggage carousel in Dublin. So there's a big red bag on top of it, saying that a lot of bags look very similar. Are you sure you've got your own bag? Now, Belfast City, we're a bit blunter. We says, have you collected your bag at all? And again, red to catch your attention. And you'll notice as well, a lot of warning signs are yellow and black. So we'll come back to that in a wee minute. And there's the close-up of it. Make sure you've actually collected your bag at all. So again, as I said earlier, our basic philosophy in healthcare, or in aviation rather, which can apply to healthcare, is three things again: avoid, trap, mitigate. So we try and stop the accident happening or the mistake happening in the first place. We assume some are going to go through. We then try and trap them. We also assume we're going to miss some of those, and then we mitigate the next ones. So at that stage, it's too late to actually stop the mistake happening, but we can reduce the impact of the outcome. Now, just to wrap up, I'll just look at one thing which has been done in healthcare, which was translated from aviation, and I don't think has worked particularly well because, to be honest, anyone I've spoken to in healthcare hasn't really understood the point of a checklist. Any of the healthcare staff I've spoken to, the big focus is it signed and is it in the notes to keep the lawyers happy? That's not the point of a checklist. In aviation, we see the checklist as the final thing that'll protect me to stop me killing myself, because the big difference in aviation is if I make a mistake, I go down with the ship. In healthcare, if I kill a patient, well, there's another one being sent up shortly. Okay, so checklists were brought in about 10 years ago. Now, you've probably been using them, and I don't know if you find them useful or not. Again, a lot of people don't really seem to understand them. Here's our checklist. This is a 321 checklist, which I was on last year. I just want to focus on one small bit of it. Now, this it's an A4 sheet that covers our entire flight. So everything we need for the whole flight's on the one sheet. We don't even have to turn it over. And the landing check is there, excuse me. We'll just look at that ECAM memo bit. So that's basically, ECAM is a screen in front of me on the dashboard. And you can see the check there is landing no blue. So when I'm coming in to land, we just check landing no blue. And just in case the screen doesn't work, we have a backup there where it's actually written down physically in front of us. So again, where can this go wrong? What's plan B? So when I'm coming in, once we get about 2,000 feet off the ground, the plane realizes it's coming in to land. And it actually displays that bit of the checklist on the screen in front of me. So that's the electronic centralized aircraft monitoring screen, so ECAM. So ECAM memo, landing, and the check was landing no blue. Now you can see there's loads of blue. So bottom lines, we're not ready to land. And if you look there, when we are ready to land, all the blue bits disappear. So the wheels are down, the brakes have been armed, and so on. So we're now ready to land. So the check then will be landing no blue. So I can see that. There's a close up of it. I can see now that we're actually ready to land safely. If it's not, the plane will actually tell us, it'll actually talk to us and tell us too low gear, too low flaps, whatever. So there's multiple layers of safety nets to try and protect us. You guys generally don't have that luxury. That needs to be designed into a lot of your equipment or a lot of your procedures. That needs more than yourselves involved. Again, that leads us to managers having to talk to manufacturers and pharmaceutical companies. Again, you've been doing the checklist for about 10 years now. I think it's a great idea if it was used properly. There was a study done in Germany last year, which looked at theatres in Germany. It was a paediatric unit. They studied 1,800 cases and they deliberately introduced 120 errors to see would they be spotted. And the outcome was 54% of them were spotted. So using the checklist, staff missed half of the mistakes. So rather than use the checklist, they'd have had the same results if they had tossed a coin. So that's a sign that the checklist isn't being used properly. It's just seen mainly as bureaucratic rubbish and extra workload, whereas in aviation, we see it as our last line of defense that'll stop me killing myself. So I think the mentality is different, and I think we're still trying to get that mentality across in healthcare. So that's a very quick summary of my world versus your world and how we can do it. So just to summarize before we wrap up, again, the two big take-home messages: errors, nothing to be ashamed of. So we expect to make mistakes, so we see no issue with putting our hand up. And secondly, our whole philosophy, where can this go wrong? And what's plan B? Everything we do is, like, say, if I'm taking off, I'm going to New York now on Sunday. As I'm heading down the runway in Manchester, if I have an engine catch fire just as I'm taking off, what's plan B? Say if they've worked out, can I get back into Manchester in these weather conditions? If not, where can I go? Can I go to Heathrow? You always have to have a plan B. Okay, so like I said, this is our approach won't translate directly into your world, but the underlying DNA will. I think if you translate that framework, I think with your cooperation, we could modify it to make it work in each of your environments. Now, it'll need change, it'll need constantly upgraded as things change in your environments, but I think it's very transferable. So say if you want to follow any of the stuff up, the website is frameworkhealth.net. There's direct links to me on that. And so say I've got my TEDx Norman talk on that as well. It's actually a TEDx Women. I was brought along as the token man to speak that day. That'll give you an idea of the same sort of approach. And as Helen says, if a book came out back in June, it's available from all the usual sort of places. Waterstones have it, Amazon have it, a lot of the independent bookshops have it as well, and it's now available in the States and Canada too. And you'll notice I mentioned earlier that a lot of warning signs are yellow and black. So that's why the cover is yellow and black. Same idea. Subconsciously, your brain sees that and thinks warning signs. That was the philosophy behind that. So a lot of thought goes into this stuff. And finally, that's all I have for you. So this will take you directly to a Microsoft Forms feedback form. If you had a couple of minutes, most of it's a drop-down menu, or if you have time, there's a few comments you can add in at the bottom then. Any feedback would be very welcome. That's how I basically change the courses. The course changes every time it's given, according to the feedback from the people that have been on it. If you tell me what works, what doesn't work, what can be done different. So any feedback would be very welcome. And there's no snowflakes here, so don't be afraid to be blunt either. Okay, so thanks for your time, and I'll take any questions that you have.
Thank you.